Right. We got cut off at the end of the part one video, and had just finished up talking about confirming placement of the endotracheal tube. So now I just wanted to move along and discuss providing communication for the patient. So, as you can imagine, if you're a patient in the hospital and you're on mechanical ventilation, where you're having an endotracheal tube placed, that endotracheal tube is going to pass through the vocal cords, so it's going to prevent movement of the vocal cords and airflow through the cords. So this is going to be kind of a frustrating aspect for a lot of our patients because that is going to make it so that they can't talk. Tracheostomy tubes will allow for vocal cord movements because the surgical site is below where your vocal cords is. But because the tracheostomy tube is in the airway in such a way with a cuff typically, that is going to prevent any airflow from going through those cords. So a lot of times we use things like communication aids like letter or phrase or picture boards to help the patients communicate their needs. Some patients will try to do like written messaging, or a lot of times they will try to expect you to lip read whatever they're trying to say to you, which can have varying degrees of difficulty depending on the patient. So these communication aids, like the one I'm showing you in the picture here, can be very, very helpful, where the patient just has to literally point to kind of what they want to communicate. We also, for conscious patients who have long-term trachs, or those that are ventilator dependent, that communication can be enhanced by using something called a talking trach. These are kind of special airways. They have a separate inlet for compressed gas, which escapes through the vocal cord for phonation. Okay, so this talking trach will allow for this gas flow. The patient will occlude this port with their thumb. That gas flow will then go up through the vocal cords here and allow for that phonation. So these talking traits can be very effective, but they may cause things like air leaks in patients that have fresh trachs. So that means that air is going to kind of leak out into some of that subcutaneous tissue, which can cause like some subacute emphysema and crackling of free air that filled up there. And also, because it's gas flow, can cause some mucus drying or irritation. And if the mucus kind of gets dried out and thicker, that airway can become occluded with secretions. Bloom fenestrated trachs are also special speaking trachs that allow for vet-dependent patients, again, to speak with fully inflated cuffs. So these are those fenestrated trachs that have the hole kind of on the top. This cuff can remain inflated, and then some of the air is going to go through the tracheostomy opening here, but some will also end up going up through this hole and being able to pass through the vocal cords, and the patient will be able to speak with that cuff inflated. I'm just going to play this video. So kind of an alternate to like the talking trachs would be to use kind of a one-way valve or a speaking valve on the external opening of the trach tube. This allows for air to kind of pass in through the tracheostomy tube, and then it's got a one-way valve that will block this exit here and then allow for air to pass up through the vocal cords. So this is kind of a quick video that shows how that valve works. Let me just, sorry, 1 second. Having struggles today.
The passimure tracheostomy and ventilator swallowing and speaking valve.
Good Lord.
The passimure tracheostomy and ventilator swallowing and speaking valves incorporate a unique patented design feature that translates into significant benefits which are exclusive to the biased closed position no-leak design. To understand the principle behind the passimure patented feature, it is important to first understand how an open position valve operates. An open position valve uses a membrane or diaphragm to perform the valve opening and closing functions. The membrane flexes during inhalation, which allows air to pass around it and through the tracheostomy tube. When the inhalation cycle reaches the passimure tracheostomy and ventilator swallowing and speaking valves incorporate a unique patented design feature that translates into significant benefits which are exclusive to the biased closed position no-leak design. To understand the principle behind the passimure patented feature, it is important to first understand how an open position valve operates. An open position valve uses a membrane or diaphragm to perform the valve opening and closing functions. The membrane flexes during inhalation, which allows air to pass around it and through the tracheostomy tube. When the inhalation cycle reaches its peak, the membrane temporarily relaxes and returns to its normal position. At this point, the valve is not actually closed. Reversed airflow, which is produced by exhaling, is necessary to force the membrane against the valve body to produce a seal. Before the membrane actually closes, there is a short time lapse where some exhaled air can escape. In addition, some common breathing patterns create an airflow phenomenon that can cause the membrane to vibrate or oscillate, which prevents it from completely sealing, resulting in noise as air leaks out. The open position valve allows secretions to travel up the tracheostomy tube and potentially occlude the tracheostomy tube in the valve. The passimure valve has a patented feature that virtually eliminates the possibility of these kinds of problems. This feature creates a closed position, no-leak condition. The membrane's outer perimeter is forced to normally be in a state of compression against a lip inside the valve body. In a relaxed state, the valve is completely sealed, not requiring reversed airflow to close it. When inhalation begins, the membrane easily bends out of the way to allow air passage with minimal resistance. When the inhalation cycle reaches its peak, air stops flowing and the membrane instantly returns to its normal fully sealed position. This is the closed position no-leak feature. As exhalation begins, the valve is already closed, and air immediately follows the path of least resistance up through the trachea and past the vocal folds, exiting through the nasal cavity and mouth. Because the valve closes at peak inhalation, a column of air remains in the tracheostomy tube at all times, creating resistance to secretions entering the tracheostomy tube and the valve.
All right, sorry, I'm not sure why I'm dysfunctioning here with my playbacks when I'm in screenshot mode, but back to this. So just a couple important functions of the speaking valve or pieces with using speaking valves is that it's really important that you deflate the cuff when you are utilizing it. Okay, so you have to have that cuff deflated. If it's not deflated, then the patient's not going to have any ability to exhale because of that one-way valve. So you need to make sure that the cuff stays deflated. You may then, because that will cause a leak, you may need, if the patient's on the ventilator, to increase their tidal volumes a little bit. You want to make sure you're only using these on eligible candidates. So patients kind of go through a process, usually speech therapy helps out with selection process where we're looking for medically stable patients who are able to communicate anyway. You're not going to do this on somebody who's got altered mental status or comatose that's not going to talk to us regardless of the speaking valve. And then because the cuff is going to be deflated, you want to make sure that you're doing this on patients of low risk for aspiration. So you want to make sure that with using speaking valves, that you want to have cuff pressures be or tracheal pressures be maintained below 5 centimeters of water pressure. Okay, and that is just to ensure that the patient isn't having excessive strain on their airway while they're using this. So typically when during that initial placement of the speaking valve, we want to make sure that that patient's able to exhale around that tracheostomy tube. So we measure these tracheal pressures during exhalation with that valve in place. So there's some pretty good pictures in your book about kind of the setup of just putting a manometer on the end of this to monitor this. If that tracheal pressure during exhalation is greater than 5, that may indicate that there's too much resistance to airflow in the patient's trachea or upper airway. So typically the things that we'll look at is looking at changing the size of the tracheostomy tube. So we'll downsize it to make sure that it's smaller. It's not creating such an obstruction in the airway. We'll look at tube position, make sure that the tube isn't up against any of the tracheal walls. Ensure that the cuff is actually deflated, and then finally look for any upper airway abnormalities that are causing increased airway resistance. So whenever you have a speaking valve in, you always want to make sure you're monitoring your patient carefully. So you want to assess their heart rate, respiratory rate, and saturations. And again, the benefits of, using speaking valves like this is not only to facilitate communication, but to kind of improve airflow over the upper airway. That helps with the functioning of the vocal cords. The patient's going to have a better sense of smell, fewer secretion problems typically, and that this is also going to help them improve their swallow function with less risk of aspiration. So it is very beneficial in able patients to move them to speaking valves early, help not only with just kind of their ability to communicate and levels of frustration, but with the benefits of, then they're utilizing their upper airway more, and that's going to improve their swallow function. Okay. So because we bypass the upper airway when we're using artificial airways, we want to make sure that we're supporting humidification, filtration, and heating of the gases that they breathe in, because those are the functions of the upper airway. So if we fail to do this, this is going to cause a lot of thickening or drying out of the secretions, and that decrease in that ciliary function. We learned about, kind of the risks with this when we talked about the upper airway and the function of the upper airway in cardiopulmonary physiology at the beginning of the semester. So one of the ways that we do this is using these things called heat moisture exchangers. So heat moisture exchangers are devices that typically they have a HEPA filter inside of them, and then they've got kind of like material that's going to trap the moisture and the heat of the air that I breathe out. And then when I breathe back in, I'm going to rebreathe that same moisture and heat, which is going to keep my airways properly humidified. Okay, so HMEs are a very effective way of doing that in the short term. Typically, if you have any patient that you're concerned about their secretions, you're concerned that they have thickened secretions, or if they're going to be on mechanical ventilation for a long time, that's when we switch to these heated humidifiers. This is going to give you a better relative humidity. It's going to ensure that we're maintaining the temperatures that we want for the gases that we breathe in. And then you also have a less risk of occlusions. These HMEs sit kind of right at the beginning of the airway, right between the patient and the Y adapter. So right right at the patient airway. So a lot of times these can get either kind of clogged with a lot of humidification where they get really, really wet, and that can increase airway resistance and obstruct the airflow. And a lot of times patients will cough secretions and things like that, and then these get clogged with secretions, and that can also cause an obstruction or a partial obstruction to the airway. So there's a little bit less risk of that when you're using these heated systems, but these heated systems also just by the nature of relative humidity, these can have a lot of condensation in them, a lot of rain out, which then can cause unintentional aspiration of like ventilator tubing fluid in the patients as well. So nothing's perfect when we're trying to bypass the upper airway and try to keep everything humidified, but these are kind of our good two options. This, like I said, typically used more for short-term ventilation needs, and then longer-term or complicated patients would get the heated humidifiers. Right, moving on to nosocomial infections. So nosocomial infections, back from infection control and survey, we talked about this being kind of hospital-acquired infections. So infections that happen to patients because they were hospitalized. So our patients that have these artificial airways or tracheal airways are very susceptible to bacteria infection colonizations in that lower respiratory tract because we are bypassing our normal filtration systems, and this is kind of an invasive thing to have these devices inside their airway. So there's a couple of signs of infections that, you need to make sure you're aware of. Any changes in the secretion, so color, consistency, amount might be a sign of infection. Changes in the patient's breath sounds as their airways get kind of clogged with excessive secretions that can cause wheezings, crackles, rhonchi. The chest x-ray, you might see areas of opacity that could indicate infiltrates or atelectasis. Patients may present with a fever, especially bacterial infections usually include fevers with along with an increased heart rate and leukocytosis. Okay, so there's several reasons why tracheal airways increase the incidence of pulmonary infections. Those are in box 37.7 in your book on page 775. So bypassing that upper airway filtration, increasing the aspirations of those secretions from the pharyngeal airway. Contamination of equipment, that's a big one. We're kind of responsible for this. I will kind of harp on you guys a lot in life support about the importance of wiping down your equipment that's even if it's in the patient's room. And you're not removing it to go to another room just because, and I will tell you this a million times when you're out in clinical, watch how many times people touch your vent screen with dirty gloves in a day. I mean, your vent is probably one of the bigger things that is going to beep in the room. So a lot of people will be doing procedures with the patients and then taking their, using their dirty gloved hands, contaminated hands to touch your touch screen on your ventilator. And you'll also notice people coming into the room to quickly silence alarms and not doing good proper hand hygiene and touching the dirty vent surface. So it's any high touch areas in patient rooms. I always think it's a good practice to make sure you're disinfecting those daily. I know housekeeping comes in and cleans the rooms, but we're all a team and we all share responsibility with this stuff. They're going to be nervous about touching your equipment, so they're probably not going to wipe it down for you, which is good because you need to be careful about what you put on your touch screens. But contamination from our equipment is a big reason why patients have nosocomial infections in the hospital. And then finally, like impaired mucociliary clearance in the trachea or damage from the tube or suctioning, and then patients not having a very good effective cough. So in order to kind of guard against infections, we as respiratory therapists should avoid introducing organisms into the airway. Okay, so should be our main goal is not being the reason why organisms got down in the airway. And we can do this by adhering to sterile technique during sectioning, um, ensuring that only aseptically clean sterile respiratory equipment is used on patients, and consistently performing hand hygiene between patient contacts. So hand hygiene is going to be a really big deal to all of you once you get out into the hospital. So making sure you wash your hands, making sure you wear gloves. So we also want to focus on preventing retention of secretions. So we do that by suctioning our patients. So obviously closed loop suction systems are probably the most efficient at clearing the airway and maintaining a sterile environment. Using chest physiotherapy on our patients when indicated, and ensuring that we have adequate humidification. And then finally, for our tracheostomy patients, routine cleaning and changing of that inner cannula of the tracheostomy tube is really going to be a key factor that's going to help minimize bacterial contamination and infection. Okay. Finally, there's some other things that we talk about when we're going to talk about ventilator associated pneumonia and prophylactic things that can be done. And a lot of those include like certain types of medications that are used as stress ulcer prophylaxis. So I think the medication's called like sucralfate. It's a medication that neutralizes or tries to neutralize gastric pH to help with acid reflux that patients that are on the ventilators are really susceptible to. And then that just helps the patient, if they're not refluxing, there's less risk of aspiration. We also do things like positioning the patient's head of the bed up 30 degrees to decrease that reflux, and doing continuous aspiration of subglottic secretions. Oops, I forgot to move the slide. So yeah, to prevent those pharyngeal aspirations, like I said, that's a sucralfate. I think that's how you say that. That's that medication that maintains normal pH, prevents stress ulcers, prevents reflux, keeping the patient's head of the bed above 30 degrees, and then using these high-low ET tubes for continuous aspiration of those subglottic secretions. So these endotracheal tubes have a special extra line. So this is a pilot balloon that we use to inflate the cuff. But this line here actually has the ability to suction right here above the endotracheal tube cuff. So if you think about this airway being in the patient's trachea, this cuff is inflated. Any pharyngeal secretions are going to kind of slide down the outside of this tube and pool right on top of this cuff. So you're going to have this pooling of all these secretions and pharyngeal secretions sitting on top of that cuff. So by being able to get down there and actually suction out that kind of puddle of secretions, that's going to help avoid aspirations with your patients. So these tubes, a lot of times, people will have it on intermittent suction, low level intermittent suction, so like 20 or 30. And then it just constantly is going to suction out whatever's pooling at the top of that cuff. So providing cuff care, we've talked about this before, that those cuffs are used to seal the airway. Mostly we use them, they're necessary in mechanical ventilation, and it helps to prevent or minimize aspirations in the lower airways. So there's a couple different types of cuffs that can be used. We talked about the fact that tracheal stenosis, tracheomalacia is very strongly associated with misuse of cuffs. Typically, particularly the amount of pressure that is transmitted to that tracheal wall, and how that is going to affect like the blood flow to that tissue and can cause ischemia and ulcerations and necrosis. So it's important to maintain your cuff pressures. So typically we want our cuff pressures to be 20 to 30. Your book talks about high volume, low pressure cuffs. So these are cuffs designed specifically to use less pressure so that while still being able to seal off the airway, so that we avoid any of this ischemia or mucosal trauma. So we want our pressures between 20 and 30 millimeters of mercury. High pressures cut off that blood flow, but low pressures increase the risk of silent aspiration and ventilator-associated pneumonia. So there's several alternate cuff designs that are out there. Specifically, your book talks about foam cuffs. These are designed to seal the airway using just atmospheric pressure in the cuff. So it's just foam that kind of seals off the airway. These are very, very uncommon. You really won't see these a lot. I think I've maybe seen 3 or 4 patients in my entire career that have had foam cuffs. And that is just because these are primarily used in patients who have already developed those tracheal injuries. So somebody that already has an established tracheal injury, then we might switch them to a foam cuff to avoid further exacerbation of the problems. These tight to shaft cuffs of low volume, high pressure design, these are designed so that it is going to minimize the any obstruction or increase in airway resistance that the actual device is causing in the airway. So tight to shaft means that this cuff is very kind of, think about it being kind of skinny, kind of narrow. You can't put a lot of volume into the cuff, but it's going to generate a lot of pressures against the airway. So these tight to shaft ones are a lot of times the design of tracheostomy tubes, especially because we deflate the cuff in tracheostomy tubes a lot so that the patient can breathe around it and speak, and as a way of trying to decannulate the patient. So that these are used more in those types of situations. These tight to shaft cuffs typically have to be inflated only with sterile water and not air, because otherwise that material is going to be kind of permeable a little bit to the air and then leak and cause a leak and gradually deflate over time. And then finally, there's these longer length, ultra thin polyurethane cuffs. These help, based on their design, how they're shaped, they can help prevent silent aspiration. A lot of the cuffs with the cuff design, even when they're inflated, they can kind of have folds in the cuff, and those folds and creases can kind of make little channels for secretions to kind of run down past the cuff into the lower airways. So these longer length, ultra thin cuffs, how they're designed, they kind of end up, when they're inflated in the airway, end up being kind of a more smooth, universal kind of seal. Oops, sorry. So, along with minimizing the risks or likelihood of aspiration, your book talks about different types of diagnostic studies that they do to understand how well the patient can swallow and if they're aspirating any of their feedings. So simple swallow tests can be done at the bedside. They just kind of put blue food coloring in with the patient's feeding, like tube feeding. If anybody's ever seen tube feeding before, it looks like tan grossness. And I've definitely suctioned tube feeding directly out of patients' lungs before due to tubes, NG tubes getting misplaced. So sometimes if we are worried that the patient is aspirating their tube feeding or silently aspirating while they're on the mechanical ventilator, we'll put some blue food coloring in with their feeding Then we'll suction out the patient, and if anything comes back blue, that means that some of their tube feeding is getting into their lungs. So it's a kind of indicates a positive test. Kind of a more intense or specific test that they would do would be a barium swallow test. This is done under fluoroscopy, where the patient goes down to interventional radiology or the radiology department and will swallow contrast. And this typically, a lot of times, it's a speech therapist that will be down there and evaluating where that contrast is going under fluoroscopy, looking to see if it's going down into the esophagus like it's supposed to, or if some of it's ending up in the patient's lungs. It is pretty interesting with speech therapy how many different techniques that they have to help patients, even if they're having some aspiration problems, to help them with their swallowing, improve their swallowing so that they can still eat without risk of infection. All right, so that was the end of part one. I thought I kind of crammed these together, but here is our part two. Oops, where did I go? Oh, here it is. Okay. Alrighty. So in the second video, my intention was to finish up that with the first one, but the second part of this presentation is beginning just with the understanding of tracheostomy tube care. So I mentioned already that in order to minimize the risk of infection, we want to do daily routine cleaning of the trach site and changing the ties, holders, and the inner cannula. So this would also be the time, like if I was going to do a tube exchange, I would probably do it along with trach care, where I'd be removing the old and tracheostomy tube and putting a new one in. But the kind of steps of trach care are pretty kind of basic. So first we're going to be assembling the equipment and kind of checking it out. In your book on page 778, box 37.8, that gives you a list of the equipment that you're going to use for this. You're going to be doing some suctioning. You're going to be taking out the inner cannula and putting a new sterile inner cannula in. So you are going to need sterile gloves for this procedure. You're going to want to make sure that you explain the procedure to the patient, let them know what you're going to be doing. I always start off with suctioning the patient, trying to get secretions out of the airway before I start cleaning. So I'll suction my patient. I'm going to remove the inner cannula. If it's non-disposable, I'm going to clean it then. If it's disposable, I'll just throw it out. Then I'm going to clean and examine the stoma site. You're always looking for any signs of redness or infection or skin irritation. Then I would change the ties in the holder, make sure I have clean, dry ones on, and put in a new clean inner cannula. Okay. After I put in the new clean inner cannula, I'm going to reassess my patient, possibly suction again if the patient needs suctioning after the procedure, and make sure that they have kind of adequate breath signs, vital signs, and oxygenation, and they've had kind of no adverse effects. So we change, like I said, we change tracheostomy tubes routinely, but we also might end up having to do this if we expect that there's a mucus plug or the cuff is damaged, or we can do it therapeutically if we're looking at downsizing the trach, trying to get the tracheostomy out. So we might switch it to a smaller size purposefully. You as a respiratory therapist will replace trachs in your career, but we only do it after the trach is considered established. So once that stoma site is healed, that surgical site is healed, typically that's about 7 to 10 days post-operation. So for changing a tracheostomy tube, we want to make sure that we have emergency equipment available. So that's first and foremost. I don't want to pull out somebody's airway without the means of emergently putting it back in. So I would probably have, usually, not to scare anybody, because it's pretty straightforward. It's really pretty easy, especially with, established trachs, to take the old one out and put the new one in. You're just pulling a tube out of a big hole and putting a new tube in the big hole in their neck. But you should probably have intubation equipment available, just in case there's an issue. So again, you're gonna assemble and check the necessary equipment. The equipment should be the same as, or mostly the same as, what you used for changing out the trach. The only different might be that you would want to have kind of a new tube plus one size smaller, and then water soluble lubricant to help insert it. Those are the only two differences with equipment that you need for trach changes versus trach care. You want to explain the procedure to the patient again, prepare all the equipment, prepare the patient. So typically we ask the patient to sit in a position where their neck is kind of extended so that you have easy access, without risk or minimizing the risk of contamination. You want to make sure that you've suctioned the patient, hyperoxygenated the patient. Then you're going to be removing the old tube, inserting the new tube. After you insert the new tube, you are going to want to make sure you confirm placement. Okay, so you need to confirm placement by having making sure that there's airflow around the tube, that the patient, has good bilateral breath sounds afterwards. And then once we've confirmed placement, we want to secure the tube with new holders and reassess the patient. So when we're looking at troubleshooting airway emergencies, we're looking for clinical signs of respiratory distress. So, we've discussed all of the kind of routine aspects of airway care, but there are going to be some times that you're going to get a stat phone call from a nurse to come to the bedside because something's wrong with their patient. So a lot of times these patients are going to present, or their physical presentation is going to be in respiratory distress. There might be some changes to their breath sounds. So the patient might sound wheezy or stridorous, or decreased because there's no air movement or absent. If the patient's on the mechanical ventilator, you might hear a lot of alarms going off, like specifically kind of high pressure alarms if there's any type of obstruction, or low pressure, low volume alarms if there's any significant leak or the tube got displaced. So some ways that the first thing you probably need to do is just differentiate between whether you think the airway emergency is being caused because of something's obstructed versus something's leaking. So obviously the treatment is going to be very different whether it's an obstructed airway or a leak that's causing the issue for your patient. So tube obstructions can happen a couple different ways. This is probably one of the most common of the airway emergencies. So it can happen because of kinking of the tube, or if the patient's biting down on the tube. So we can fix the problem then by kind of moving the patient's head or neck or repositioning your tubing to, fix the kink, or putting in a bite block or an oral airway to prevent the patient from biting down on the tube. You'd have that herniation of the cuff over the tip. If this happens, I've kind of talked about this in class before. If this happens, you want to deflate the cuff then. If you deflate the cuff, your obstruction should resolve itself. If it doesn't, you can try to see if with the cuff deflated, you can pass a catheter through the tube, because that should move the cuff out of the way. You can have an obstruction from the tube against the tracheal wall. And then mucus plugging is probably the most, besides kinking or writing, plugging is probably your most likely culprit, where you've got a secretion that's blocked off the airway. You can try suctioning, um, and you, again, we don't always like to lavage our patients, but typically seeing if you can pass a suction catheter is going to be helpful to remove any secretions. Okay, so this is just kind of a nice picture that kind of demonstrates this. So this would be like an kinking or biting of the endotracheal tube would be causing this obstruction. This is kind of a picture of what a tube herniation would look like. This one, number 3, is the tube kind of up against the tracheal wall. And finally, number 4, this is the obstruction from mucus plugging. Cuff leaks can happen from a leak in the cuff, in that pilot tubing, or in that valve that's on the pilot balloon. All of those can cause some sort of an airway leak. And this can be a real issue with patients who are receiving mechanical ventilation because that cuff needs to be sealing the airway in order for positive pressure ventilation to be effective. So if I have a leak, this is going to greatly reduce the amount of tidal volume I'm able to deliver to the patient. Okay. So if I'm not getting good volumes in, my patient's going to be hypoventilated, meaning that they're not getting adequate ventilation and their carbon dioxide levels are going to increase and their oxygen levels are going to decrease. So if it's a problem with the pilot tube or valve that's leaking, you need to probably exchange the tube. So you're going to use a tube exchanger to exchange out the tube. There are pilot valve repair kits that you can use temporarily to avoid having to exchange the endotracheal tube or the tracheostomy tube. Actually, instead of buying really fancy repair kits, a 3-way stopcock that nurses use for their IV lines can be really effective, at least, again, temporarily. If the cuff is ruptured, where that means like the cuff has burst, that is going to require extubation and reintubation, or the use of, again, that tube exchanger. So the tube exchangers, you guys did that RCC for me already. That is those long, kind of semi-rigid tubes. The blue ones are called bougies. I'll show you this in lab. And which, is just something that you're going to insert into the old endotracheal tube. You can slide the old one off and then use that as kind of a fast track to putting the new one on. And we also have ones that are called Cook tube exchangers, and Cook tube exchangers actually have a port that allow you to ventilate through, but bougies don't. So. All right. So another kind of airway emergency could be accidental extubations, where the tube becomes partially displaced out of the airway or trachea. Typically with these, the patient's going to have those diminished breath sounds because they're not going to be ventilating well. There's not going to be a lot of airflow through the tube. And sometimes when you try to pass a suction catheter through the end of the tube, you're going to do it without meeting obstruction or eliciting a cough, meaning that it's probably in the stomach or out too far up out of the airway. So with positive pressure ventilated patients, a lot of times you'll hear the airflow coming out the mouth and the nose, or you'll hear the air going in over the stomach. And that's going to be a pretty key indicator that your tube's not where it's supposed to be. If you believe that there's a partial extubation or a displaced tube, then you want to make sure you're completely removing the tube, providing that ventilatory support with a manual resuscitator and mask, and evaluating the patient to see if they need to be reintubated. Okay, so sometimes patients take out their tubes, and it's kind of a good thing because, like, oh, well, we were planning on getting rid of that anyway. We always prefer if they wait for us rather than doing it on their own, but not every time that a patient accidentally extubates themselves doesn't mean that we automatically have to put it back in. We always kind of want to, evaluate the patient a little bit and see if they might be successful off the ventilator at that point. So if you have to provide resuscitation to patients who have extubated themselves, um, or have removed their tracheostomy or displaced their tracheostomy, your book does cover some, special circumstances where it might not be obvious to you how you're supposed to manually ventilate the patient. So obviously, if it's an endotracheal tube, it comes out. We're just going to put one of those um, oral nasal facial masks on the patient and use a manual resuscitator over the patient's nose and mouth and bag the patient. Okay, that's what we've practiced in lab a lot. If the patient has a tracheostomy tube, you're going to want to cover the stoma with gauze. So that, let's say the patient's tracheostomy has come out, you cannot get the new tube back in, and the patient's now looking like they're not doing very well and you need to manually ventilate. So you're going to cover up that stoma with gauze and you're going to provide manual ventilation to the upper airway. For laryngectomy patients, remember these patients are the ones who their surgery has disconnected their lower airway from their upper airway. So using manual ventilation with a mask over their nose and mouth is never going to effectively ventilate the patient. So to provide manual ventilation with these patients, they recommend using a really small size mask over the stoma site, and providing manual ventilation that way. Some patients have partial laryngectomies. So in those cases, you want to attempt it both ways and, go with the route that's giving you the best chest rise and the most adequate ventilation. Okay. So moving into extubation and decannulation. So this is meaning we're doing this on purpose. Our patient just didn't take things out on their own. This is a process for removing that artificial airway. So most of our patients that we put on the ventilator are expected to eventually come off the ventilator. They're going to eventually get extubated. Typically, we see most patients intubated in the hospital nowadays. We try to get them off within, 3 days of intubation. Your risks of complications go up after being on the ventilator for more than 7 days. So we try to avoid that by extubating early. But in certain situations, patients are going to end up with permanent tracheostomy tubes. Those patients, these are kind of common in patients that have been treated for like throat cancer, laryngeal cancer, or for patients who, due to their condition, need long-term ventilation. So if you have kind of progressive respiratory disease, like restrictive respiratory disorders or obstructive respiratory disorders, that make it so that you don't ventilate adequately on your own and you need the help of an assistance from a positive pressure ventilator, you probably were going to end up with a permanent tracheostomy tube. So when you're assessing for readiness for the patients who are going to be extubated, you first want to make sure that whatever the reason you put the patient on the ventilator in the first place no longer exists. So if I intubated this patient because they weren't oxygenating well, I want to make sure that they're oxygenating well before I extubate them. I want to make sure that they have adequate ventilation. I want them to be able to protect their own airway. We do that a lot by evaluating whether they have what we call an intact gag reflex. We want to make sure that they can manage their own secretions and that they have kind of a patent upper airway. So to help predict the risks of developing glottic edema or stridor extubation after extubation, we perform something called a cuff leak test. So when this is just where we deflate the cuff on purpose, and we're looking for the sounds of kind of airflow around that cuff. If I hear airflow and I hear that leak, that's telling me that my airway is not too swollen. If I didn't hear any leak at all with the cuff deflated, that would mean that my airway is kind of swollen around my endotracheal tube. And if I would take that airway out, that swelling could cause partial upper airway obstruction. So the presence of a leak on a cuff leak test is good. It indicates that there's no significant airway edema. So the procedure for extubation, we're going to assemble all our equipment. We want to make sure we're checking it. You want to make sure you have suction equipment ready. You want to make sure that you have oxygen equipment ready. Syringe is necessary to deflate the cuff. And then I always like to be kind to my patients and my nurses. And I usually put like chucks or towels down on the patient's chest to pull all of this equipment out on, because it's going to be covered in pharyngeal secretions, and you're going to make a big mess if you don't kind of put some padding down or some drop cloths down beforehand. So after you suction the patient's endotracheal tube and pharynx above the cuff, you want to make sure that they're oxygenated very well before and after suctioning. Then I'm going to deflate the cuff. And I usually tell my patients to take a deep breath in when I remove the tube. Okay, so the purpose when we're removing the tube, we want to make sure that there's maximum abduction of the vocal cords, meaning that the vocal cords are as open as far as I can possibly get them. So when I take a deep breath in, that opens up my vocal cords as far as they can. The other thing that can cause, and your book kind of covers it, the other technique that you can use is is to have the patient cough. So kind of the first method is that large breath, and then the tube's removed during that peak inspiration. And the second method is that the patient coughs and the tube's pulled out during that cough. Okay, so both of those techniques cause that maximum abdication of the vocal cords. Okay. Number 6 is just applying oxygen and humidity afterwards. So like I said, you want to make sure you have oxygen ready for the patient. Some patients, if they have a lot of glottic edema or risk for that, you might want to put them on a cool mist aerosol to help with the airway edema. And then you're going to assess and reassess your patient. So kind of the most common problems after extubation are going to be hoarseness, a sore throat, and cough. Some of these complications happen not immediately after extubation, but maybe within 24 hours of extubation. So you really want to be following up with these patients. Laryngospasm, we've talked about before. This is kind of rare, but it has sometimes a serious but can be a serious complication where that larynx just spasms. You would want to treat it with high concentrations of oxygen, maybe some positive pressure, like putting the patient on CPAP. But ultimately, if it's not correcting itself, you're going to want to use a neuromuscular blocking agent, which is kind of a paralytic. And then you're going to have to manually ventilate and re-intubate the patient. Vocal cord dysfunction can be kind of temporary, but it's important to be considerate of it because it could cause aspiration. So if those vocal cords aren't moving the way they're supposed to be, and we're allowing our patients to eat, then they can definitely aspirate and end up introducing organisms down into their airway. So a lot of times we don't like to give our patients food or water right after extubation, especially if they've been intubated for a while. So some recommendations are NPO for 24 hours, which means nothing by mouth for 24 hours. But I would say clinically in practice, we're a little bit kinder. Most patients really want, mostly it's water right after getting extubated. So after a few hours after extubation, once they've kind of established that the patient looks pretty good, they'll maybe lighten up on that NPO order. Um, Extubation failure is going to be defined as the sudden need to be put back on the mechanical ventilator. Can be due to any kind of airway problems like swelling, or it could be because of ventilation issues that occur anytime, up to 8 hours within extubation. When we get to mechanical ventilation, they're going to talk about extubation failure being anywhere within 48 hours of extubation. But for airway management, anytime you need to be re-intubated due to ventilation needs, aspiration needs, or airway needs like edema, that's considered a failure of extubation. So decannulation is considered the process for weaning and removing the tracheostomy tube. So this may be, we might kind of do this automatically, but if the patient's been on mechanical ventilation for a long time or been trached for a long time, we might need to do kind of what we would consider a weaning process, where we gradually kind of put more of the expectation on the patient to maintain that airway. So anytime patients have been on the mechanical ventilator for extended periods of time, they might have those problems with that muscle weakness or problems adjusting to the increase in anatomic dead space. So if you think about it, all of that upper airway, they haven't had to breathe through while they've been trached. So when we remove the trach, now they have all of those conducting airways to fill, so their work of breathing is going to increase. And then sometimes there's upper airway problems or secretions that we aren't aware of until we take out the tracheostomy tube. So for these patients, that weaning process is necessary rather than just abruptly removing the tube. And we can do that weaning process through things like fenestrated tubes, or using progressively smaller tracheostomy tubes, or things like tracheostomy buttons. So typically when we're assessing our patient for decannulation, we want to make sure that the patient has sufficient respiratory muscle strength. So that means that they can achieve like a peak expiratory pressure greater than 40. That they have no active infections or no excessive amounts of secretions. Sometimes we can use a bronchoscope to assess their upper airway to make sure that their upper airway looks patent. And we also want to make sure that there's good muscle strength and good coordination of muscles by the patient, demonstrating they have an adequate swallow. So again, fenestrated tracheostomy tubes are tracheostomy tubes that have an opening on that posterior wall, above kind of that outer cannula above the cuff. So by removing the inner cannula, this opens that fenestration and allows air to pass into the upper airway. So typically we can use a cap, or we can put a speaking valve on the opening of the trach, along with that fenestration, and deflating any cuffs that might be there. That allows us to assess that upper airway function. We can then put, we can take those caps or speaking valves off if we need to suction the patient. And then if the patient requires mechanical ventilation again, all we have to do is reinsert that inner cannula, inflate the cuff, and we're back to having a patent artificial airway to use for that. When we're using progressively smaller tubes, this is kind of similar to fenestration, but in this approach, we're kind of increasing the use of that upper airway by putting smaller and smaller airways in the patient's trachea. So this is a methodology we use a lot of times for patients whose airways are too small for like fenestrated tubes that are out there. By using this progressively smaller tube, this might help with stoma healing. So especially if stomas have been there for a while, by reducing the size of the tube that's inside that stoma, that might help it with closing ultimately. Um, But be aware that because I'm decreasing the diameter of these tubes, that's going to increase my airway resistance. That may impair my patient's ability to cough. And that smaller size may then not fit inside my airway appropriately and cause pressure on those tracheal walls. Okay. Tracheal buttons. These are kind of funny. A lot of times people get these confused. They think tracheal buttons are those red caps that we put over existing trachs. But tracheal buttons are different. Tracheal buttons are like this. I almost feel like it looks like kind of a little bit of a placeholder. So this is an example of a tracheal button in a stoma. So this is just kind of a washer, whatever you will. I'm not that construction minded, so I'm probably using the wrong term. But this just kind of maintains and keeps the stoma open. It just sits right inside the trach, so it's not going to increase airway resistance because it's really not in the trachea. It's just sitting in that stoma and maintaining that open stoma. There's going to be no cuff to this. So it's just maintaining that open stoma. It's not going to do anything within the airway to relieve obstruction. And it is also a little limited in aiding in secretion removal. You can still suction through this, but it's not as easy to do as with an actual tracheostomy. So when we're assessing for post-decannulation, after we've taken the trach out, we want to make sure that their vocal cords are working the way they're supposed to. So we assess for vocal cord responses, because anytime you have vocal cord dysfunction, that could cause aspiration, or it could be causing an airway obstruction. So some of the common symptoms are going to be stridor, retractions, any inability to feel air flow through that upper airway, which means, if I can't feel any airflow through the patient's nose or at the patient's mouth, that means that there's some sort of an upper airway obstruction. And because we're always wanting to evaluate our patients carefully after we extubate or decannulate, we want to make sure that we have suction equipment and emergency intubation equipment at the bedside, just in case the patient ends up not tolerating it well and we need to re-intubate quickly. All right, so that is the end of part 2, or your airway lectures for the semester, actually. So if you have any questions, please let me know.